So yeah, evaporatin can be useful in the heart failure patient, but it's not the pillar which is given by the AHA. So answer is the C. Evaporatin is the answer. Next, please.
Next slide, please. Which of these is not a part of triple drug therapy for maintenance immunosuppression post heart and lung transplantation? And the answer is basiliximab. Dr. Chitan Chettis.
The answer is D. Basiliximab. Because if you see, basiliximab is the induction immunosuppressants, and here we have asked the maintenance immunosuppressants. So generally, induction immunosuppressants, when we induce the patient during anesthesia for the transplant, that time we give either basiliximab, which is most commonly used, and patient has high HLA antibodies positive, then we can give an antithymocyte globulin, that is ATG. Maintenance immunosuppressants, we give generally calcineurin inhibitors like tacrolimus, anti-metabolite like mycophenolate, and corticosteroid like mostly prednisolone. So maintenance is all these three drugs, and basiliximab is for induction immunosuppressants. Next slide, please.
Cutoff value of VO2 max for heart transplant candidacy for heart failure patient on beta blocker is?
Yeah. So answer is
The
C.
answer is less than 12 ml per kg per minute. Yeah, please go ahead, sir.
Yeah. So this is whenever patient comes, any heart failure patient with end-stage heart failure with irreversible heart failure condition. First of all, first we do is the cardiopulmonary exercise test, and that is we see the what is the VO2 max. And in 2024, ISHLT has given very clear-cut guideline. If that patient, heart failure patient, is on beta blocker, then VO2 cutoff is less than 12 ml per kg per minute. So if it is like 11 or 10, we can post that patient. We can list that patient for the heart transplant. If like VO2 is more than 15, 16, that means more than 12, when we should wait for that patient to put on the list. And every 6 months, we can repeat the VO2. If patient is not on beta blocker by any reason, then cutoff is less than 14 ml per kg per minute. Whenever there is young patient, then instead of VO2 max only, we should also see the V by VCO2 slope if it is more than 35, or peak VO2 less than 50% predicted. So here answer is VO2 max on patient with beta blocker, cutoff is less than 12 ml per kg per minute. Next slide, please.
Which of the following is not class 1 pulmonary arterial hypertension? Can you show the answer, please? The answer is pulmonary hypertension due to LV dysfunction. Yeah, please go ahead.
So if you see the classification of the pulmonary hypertension is now well established. So class 1 is the pulmonary arterial hypertension, which can be idiopathic, heritable with drugs or with connective tissue disorders. Class 2 is the pulmonary hypertension due to left heart diseases like systolic dysfunction, diastolic dysfunction, mitral stenosis, or mitral regression. Third will be like pulmonary hypertension to lung disease like COPD. Fourth will be with chronic thromboembolic pulmonary hypertension, and fifth will be unclear and or multifocal mechanisms like hematological disorders or patient with sarcoidosis. So here answer is C, with pulmonary arterial hypertension due to LV dysfunction, that is grade 2 pulmonary hypertension. Next, please.
Yeah. As per ISHLT guidelines, acceptable value of pulmonary artery systolic pressure, pulmonary vascular resistance, and transpulmonary gradient on right heart catheterization for candidacy for heart transplant is? If pulmonary artery systolic pressure of less than 50 millimeter of Hg of either PVR less than 3 Wood units or transpulmonary gradient of less than 15 millimeters Hg. Go to Seth, please.
So this is very clear guideline given in 2023 by ISHLT. I think everyone should read this guideline. It is very comprehensive and given everything very clearly. So as I told, first when patient come with end stage heart failure, we first do the VO2 max. And once VO2 max is less than 12 ml per kg per minute on beta blocker, then second thing we do is we admit that patient and do the right heart cath, because we want to see whether this patient's PVR is acceptable or not. Because when patient has chronic left heart disease, there are very high chances that because of back pressure changes, their pulmonary vascular resistance is higher. And if patient recipient has very high pulmonary vascular resistance, then that donor heart cannot work, that especially right ventricle cannot work against that higher pulmonary vascular resistance, and that heart may become fail. So we have to do right heart cath, and what we see on the right heart cath, that pulmonary artery systolic pressure should be less than 50, PVR should be less than 3 Wood units, and transpulmonary gradient, which is the mean PA pressure minus PCWP or LA pressure, that is less than 15 mm of Hg. If it is higher in the baseline, then we give the vasodilatory challenge with the like mildrenone or maybe levosimendan, starting dobutamine, starting selective pulmonary vasodilators like sildenafil. So this is very clear-cut guideline. So once this is acceptable, then we go for the further workup of the patient. Next, please.
Which of the following is not used for treatment of pulmonary hypertension? The answer is fenfluramine. Dr. Seth, please.
Yeah. So it is very clear that fenfluramine actually increases the pulmonary artery hypertension. And what all the other options can like endothelin antagonist like bosentan or ambrisentan or sildenafil, which is the phosphodiesterase 5 inhibitors. Those all are the decrease the pulmonary artery hypertension. So your answer is very clear, fenfluramine, which actually increases the pulmonary arterial hypertension. Next, please.
Which of the following describes isolated post-capillary pulmonary hypertension? The answer is B. Mean PA pressures of more than 20 mmHg, PC wedge pressures of more than 15, and PVR of less than 3 Wood units. To say this.
So this is also clearly mentioned in a guideline published in 2023 by ISHLT. Before this guideline, mean pulmonary pressure more than 25 was considered as the pulmonary artery hypertension, but now mean PA pressures more than 20 mm of Hg is considered as pulmonary artery hypertension. Now, if we see the isolated post capillary means it is because of left ventricle related problem after the capillary means after the lung pulmonary capillaries. So whenever because of mitral stenosis or mitral regurgitation or maybe severe LV diastolic dysfunction, that time pulmonary capillary wedge pressure will go up. So it will be more than 15 mm of Hg, but PVR is less than 3 Wood units. If PVR is more than 3 Wood units, then it can be pre-capillary or capillary or combined hypertension. So whenever we are talking about post-capillary, that time only PCWP will be high. Means LA pressure will be more than 15 mm of Hg. Mean obviously high, then only we can say it's a pulmonary hypertension. But PVR should be less than 3 Wood unit to label it as an isolated post-capillary pulmonary hypertension. If PVR is more than 3, it can be either pre-capillary or combined. Next, please.
Which of the following is donor and recipient IgG profile is associated with high risk of post-transplant CMV infection in recipient? The answer is D plus and R minus.
Yes, so this is also in 2023 guideline. So post heart transplant, CMV is the very like deadliest infection, like where with very high morbidity and mortality. It's common also. So we screen the recipient when we work up for the patient recipient. That time we see what is the CMV IgG status of the patient, and when we go for the donor, we take the donor sample for CMV also, and we see what is the donor IgG status. So when donor is positive and recipient is negative, means recipient has never undergone not exposed to CMV and it has no IgG positive. So that is the highest risk of developing the CMV in the recipient because recipient have no pre-existing antibodies against the CMV. So donor positive IgG for CMV and recipient negative is the highest risk factor for developing the CMV infection post heart transplant. So this is also given in the 2023 guideline. Next, please.
Which of the following is the defining criteria for a definite usual interstitial pneumonia pattern? The answer is subpleural honeycombing.
So if you say usual interstitial pulmonary pneumonia, classic HRCT pattern includes honeycombing. So it is the distinguishing feature of VIP and must be present. So honeycombing must be there, subpleural honeycombing. Traction bronchitis can be there or cannot be there. Other features can be reticular abnormalities and distribution as that it will be subpleural with a basal predominance. So this is answer is subpleural honeycombing is the definitive criteria for the defining the definite usual interstitial pneumonia.
Next slide, please.
Next, please.
Which of the following immunosuppressants is most commonly associated with gout? The answer is cyclosporin. Go to Seth, please.
Yes. Yes. So hyperuricemia and gout are common complication of organ transplantation, with 5 to 84% of the patient developed hyperuricemia. And out of that, 1.7 to 28% have symptomatic gout. I mean, they have some small joints pain. But luckily nowadays we are not using cyclosporine, and instead of cyclosporine we are using the tacrolimus. So tacrolimus has very less incidence compared to cyclosporine. So answer is cyclosporine, but most of the time, as I told, immunosuppressants are tacrolimus, mycophenolate, and steroid, Visolon or prednisolone. So answer is cyclosporine. Next slide, please.
I request Dr. Pradeep Narayan to come into the next questions, please, to answer them. All of the following is a risk for HLA sensitization except
Yeah, so here
it
the
is
answer obviously
CRTD
is
implantation.
B,
Yeah,
because to have sensitization, you have to have prior exposure to the HLA antibodies, and that can only happen during pregnancy, transfusion, or if you put a ventricular assist device. So the choice here was actually very straightforward. I think it is the CRTD implantation.
next slide, please. Which of the following is true about inhaled nitric oxide?
So, I mean, again here, maybe there was some confusion with the word attenuate. Attenuate means to decrease. So there is a direct relationship between nitric oxide and the cyclic GMP levels. PDE5, which stands for phosphodiesterase type 5, and we know them commonly as sildenafil, they are actually useful in increasing the cyclic GMP levels. So the answer here was nitric oxide, because nitric oxide increases the level of cyclic GMP and causes vasodilatation.
Yeah. Which of the following drugs is most commonly associated with impaired wound healing in post-operative period?
So again, all the four drugs have some effect, but sirolimus has been shown to have the most profound effect on wound healing. And it is an immunosuppressant, as we all know. We know it from our, PCI information as well. It is well known to decrease wound healing. There is enough evidence. You can see there is a link there at the bottom as well. So yeah, sirolimus is the answer.
Sirolimus, yeah. Thank you. Next slide, please. Which amongst the following condition describes grade 3 primary graft dysfunction following lung transplantation?
So graft dysfunction are described taking two criteria into action. One is the chest X-ray, and the other one is the PaO2 FiO2 ratio. So here the answer was, you can see on the right-hand side of the screen, when the PaO2 FiO2 ratio is more than 300, it is grade 0 or grade 1, depending on whether there is feature of pulmonary edema on X-ray or not. So the answer was grade 3 was presence of pulmonary edema as well as the PaO2 FiO2 ratio less than 200.
Next slide, please. Immunosuppressant which can be helpful to prevent CAV.
So first of all, what is CAV? It is, I don't know if you got the full form. It is cardiac allograft vasculopathy. And as you can see, a scheduled trial was carried out to answer this particular specific question, and the drug is everolimus. So answer was A, everolimus.
Yes. Next slide, please. Which of the following is not an ideal donor for lung transplantation?
So again, it's a sort of very
Answer. Yeah.
straightforward question. I think the only answer here was the age less than more than 55 years, because less than 55 years is the ideal age.
Next
You
slide,
don't want
please.
a smoker or
You
people
want
with.
to talk anything about this? Go to the previous slide, please. Yeah, please go ahead, sir.
Yeah, so obviously the person has to be brain dead, and you don't want a smoker to be giving their lungs to a recipient. So this is a whole list, of ideal donor. There are some borderline zones as well, but I think this question was actually very simple. I think most of you would have got it right.
Sir, we have a cigarette packing of less than 20 packs per year also. Ideal donor.
Yeah.
When the question, go to the question, please. Previous slide, please.
Yeah.
So
So
we have got two answers here, sir. That is included.
yes,
Sorry,
yeah,
it's less than
cigarette
25 years.
smoking history. I assumed it was more than 20, but this question is actually uh, it should be wrong, isn't it?
No,
Yes,
no,
sir.
this is
Because
no, no,
two
this
answers are
is
there.
no, 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 no. This is absolutely fine. So, cigarette smoking, if it is more than 20 packs, yes, then it is not. Less than 20 packs, we can consider.
Correct.
Okay.
So,
Yeah.
it is right. So, answer
So the
is
answer is
only
first
one,
one, more
age
than
greater
55
than
years.
55 years. If this is more than 20, then it is not ideal donor. Less than 20
Correct.
packs, we can accept that patient as an ideal donor.
Sure, sir. Thank you. Thank you for the clarity.
Okay.
Next slide, please. Next slide. Most common cause of death within the first 30 days after heart transplant is?
Yeah, again, here the answer is very simple. It's primary graft
Go to the
dysfunction.
answer, please. Yeah.
And two-thirds of the cause of death early is due to primary graft dysfunction. Uh,
Next slide, please. Effect of basiliximab is monitored by?
So yeah, so the answer is CD25, and there is a couple of things about this that we need to know. Is that basiliximab is a monoclonal antibody. The CD25 is actually it's a compound, it's a component of the interleukin 2 receptor, and this uh, adherence is actually important for T cell growth, proliferation, and differentiation. And the action of basiliximab is monitored by CD25.
Next slide, please. What is the full form of EVLP?
Yeah, it's a very interesting question. I think all P's are possible, but the answer is perfusion. And it is mainly, it's a technique that is used to convert a borderline lung into a suitable lung. So if the lung is even slightly damaged or, just borderline, then it can be through perfusion improved into a lung that is suitable for transplant.
Next slide, please. Which of the following is not a ventilator setting for reperfused lung allograft transplant?
Yeah, again, if you look at the choices, it's
So the
always
answers,
jumping
please.
at you. It's a PEEP more than 15. The PEEP should be between 5 to 10. Actually, ideally below 5, but at the most you can put it between 5 to 10, but certainly not above 15, because that will cause sort of damage.
Next slide, please. I think Dr. Chitan will come now.
Yeah.
Yeah. As per
Yes.
ISHLT definition of PGD, that is primary graft dysfunction of LV, newly placed IUP is graded as?
So answer is moderate primary graft dysfunction. It is also again very clear-cut guideline by ISHLT published in 2014. They have given PGD of left ventricle into mild, moderate, and severe. Mild is when LV dysfunction, when only inotropes are required. Moderate when we have to put the IABP for the treatment along with inotropes. And when it becomes severe, when patient is still unstable on IABP, and when we put on ECMO or bived or something, then we call it severe primary graft dysfunction. So here IABP is considered as moderate primary graft dysfunction. Next,
Next
please.
slide, please. Radial score for primary graft failure risk includes all except?
Yes. So radius score is for the to see for the ideal donor. So if you see, it is published in 2011 in Journal of Heart and Lung Transplant. And radial stands for R is for right atrial pressure. If it is more than 10 mm of Hg, means CVP is higher. Recipient age is more than 60. D is for recipient with diabetes mellitus. I is for if recipient is inotrope dependence. Donor age is more than 30 years. And length of ischemia time is more than 4 hours. So all this, if these six are there, then patient is considered high risk for developing the primary graft dysfunction. So here exclusion is a recipient with hypertension. Most of our recipient may have hypertension and that will not cause the problem with the primary graft dysfunction.
Yeah. Next is indications for ECMO post lung transplantation can be?
So
Answer.
here definitely answer is all of the above,
From them.
because if there is primary graft dysfunction, then obviously ECMO will help in the oxygenation and maintaining the hemodynamics. If it's because of high pulmonary arterial hypertension, RV dysfunction, again ECMO will help. So ECMO has role in all the three conditions. So answer is all of the above.
Next,
Here
please.
one important thing I want to highlight is
Yeah.
ECMO will be even useful when we
Just
see
go back,
that.
please.
Can you please go back?
Go back to the previous slide, Ritesh. Yeah.
Yeah. So
Please go ahead.
most of the time, what happens in this heart transplant, lung transplant patient is they have high PVI because of pulmonary problem like interstitial lung disease. So they have mainly right ventricular RV dysfunction, and LV is chronically underfilled. Because of RV dysfunction, there is no much forward cardiac output from the RV. So when lung transplant happens, then there can be chances that LV get immediately very high preload, and that can also be controlled when you put the patient on ECMO. So when we put the patient on ECMO, we support RV also and actually LV also by controlling the LV filling, LV preload. Next, please.
Most common mechanism for PGD is?
So here answer is ischemia reperfusionary because rejection, cardiac tamponade bleeding, those are the secondary causes. So primary graft dysfunction is when there is no not known cause. So generally mechanism is ischemia reperfusion. So what happens whenever when we take the donor heart, when we deprive the heart, there will be ischemia time. There will be cold and warm ischemia time. Ideally, it should be less than 4 hours. So because of ischemia, there will be decreased intracellular oxygenation that and they cause the increase in the acidosis and increased lactate production. Ultimately, it causes the hypercalcemia. Hypercalcemia causes the intracellular mitochondrial damage and MPTP score. This is mitochondrial permission transition pores will open. And when that get the perfusion, when we open the clamp and when we now try the perfusion in the heart, then what happens because of oxygen, reactive oxygen species like superoxides, that oil also go intracellular and that will also increase the calcium and ultimately cause the mitochondrial damage and that cause the all inflammatory milieu inside the cell and that is the mechanism for the LV or RV dysfunction. So rest all are the secondary causes and this is the primary causes. So this is the mechanism. It actually is the histopathology, pathological mechanism for the primary graft dysfunction. Next, please.
All of the following hormone replacement is required for brain dead patient optimization except.
So here answer is obviously parathyroid because when patient is brain dead, then pituitary will not get the blood, and that's why there will be malfunction of the pituitary, and the hormones released by the pituitary will not be available. So we have to replace vasopressin, methylprednisolone, and thyroid hormones, and insulin to control the blood sugar. But we don't need to replace the parathyroid hormone. So answer is parathyroid, which is not required. So these three vasopressin, methylprednisolone, and thyroxine should be given to all the brain dead patient.
Yeah. Next slide. All of the following are true with tachyarrhythmias after heart transplantation except. The answer is
So it's accept. The answer is the beta blocker. So beta blocker should not be used postpartum for rate control. This is exception. Means beta blocker can be used. So here it is very clear cut guideline published in 2023 again in ISHLT. So if I read that, then so it is all the class 1 or class 2 indications. So treatment of tachyarrhythmia should be aimed at rate control. So persistent tachyarrhythmias, whether atrial ventricle, should prompt investigation of possible rejection and electrophysiological evaluation if rejection is absent. So any tachyarrhythmias, think of whether is there any rejection. Sustained ventricular tachycardia should be evaluated with both angiogram and endomyocardial biopsy again to rule out any rejection or coronary artery events. Class 3 antiarrhythmics like sotal or amiodarone can be safely used. Many transplant physicians feel that amiodarone should not be used, but guidelines says sotalol like beta blockers and amiodarone can be safely used in heart transplant recipients and have minimal interaction with the immunosuppressive agents. And non-dihydropyridines, calcium channel blockers, and beta blockers may be used in heart transplant recipients for rate control. Class 2 indication. So beta blocker and amiodarone both can be used. So here answer is the beta blocker, which is exceptional. It can be used and it should be used for rate control. Next,
next slide.
please.
Please. Indications for lung transplantation include all except. Can you show the answer, please?
So your answer is the Eisenmenger syndrome with severe right ventricular dysfunction. Bit because if Eisenmenger with severe RV dysfunction, obviously we have to go for the heart and lung transplant. Just transplanting the lungs will not cause the right ventricular dysfunction. Up to moderate, we can accept. Up to moderate RV dysfunction, when we do the double lung transplant, most of the time pulmonary vascularization falls and RV will improve. But if it's severe right ventricular dysfunction, then just doing the double lung transplant will not help, and we have to do heart and lung transplant both. So answer is D.
Yeah. Next slide, please. Which of the following suggests positive apnea test?
Yes. So here answer is increase in PaCO2 more than 20 ml of Hg from the baseline. Rest all three options are actually when that happens, we should stop the apnea test. So in apnea test is the confirmatory diagnosis for the brain dead. And we disconnect after giving the oxygen and all, we disconnect. And when we take the ABG baseline and we take the ABG after 8 to 10 minutes. And if PaCO2, if it is absolutely more than 60 ml of Hg or if it is more than 20 ml of Hg from the baseline, if it increases more than 20 ml of Hg from the baseline, we consider apnea test is positive. And if like if patient's oxygen saturation falls is in 85, or systolic BP become more than 90, we should actually abort the apnea test. Again, we have to optimize the patient, and then again we should check the apnea test. So here answer is when PSU to more than 20 mmHg from baseline, we consider positive apnea test. Next, please.
Hearts from donors with the following infection cannot be used for transplantation.
Yeah, so this is actually very tricky question, because all four can be, we feel all four can be the answer. But here again, 2023 very clear cut guideline with class 1 indication, recommendations that heart from the donor with risk factors for acute HIV, hepatitis B and hepatitis C infection are safe for transplantation, and recipients should be informed, monitored and treated where appropriate in accordance with the established guidelines, class 1 recommendations. And second is hearts from the donor with encephalitis of unclear etiology should not be used for transplantation. So here is the clear answer is encephalitis of unclear etiology should not be used.
So it's a message to all the residents that even with HIV, HBsAg and HPC transplants candidates,
Yeah.
they can be the donors for the hearts.
Yeah, but we have to see that how we suppose if patient is HIV, then CD4 count should be less than 200. So we have to consult the ID specialist. We have to inform the recipient relatives, take the consent that we are taking heart. Generally, we accept such hearts when it is like when patient is like recipient is on dying, yeah, suppose on ECMO or on IABP, and we are not getting the heart in time. Then only we generally accept such heart. Otherwise, we generally try to avoid if recipient is stable and walking and coming from the home.
Okay. Fine. Next slide, please. Identify the procedure.
Yeah, so here I answer is the endomyocardial biopsy, and that was the biotome which was shown on the figure. And endomyocardial biopsy is still now this is a gold standard for the surveillance for the heart transplant rejection. Now many other methods, the liquid biopsy, MRI coming, but still now endomyocardial biopsy is the gold standard if you want to surveillance for the rejection after the heart transplant, and it is done at the 1 month, 3 months, 6 months, and 12 months. So four in the 1 year. Different institute may have different guidelines, but we follow this guideline. So that procedure was endomyocardial biopsy.
So it should be done every year, sir, or only the first year itself?
No, 1 month, only after 1 year, not the routine protocol. If
Routine
SOS,
protocol.
if required, then. But in first 1 year, 4 biopsy will be required. After
Thank
1 year, SOS. Yeah.
Next slide, please. I request Pradeep Narayan to answer, please. Next slide. What is the median survival rate following adult lung transplantation?
So it's 6.2 years. You've got another choice, which is 11.2 and 15. Yeah, you can see it here. So heart transplantation obviously has got a much longer survival rate, but this is median survival rate. And so what it means is 50% of the patients have a survival of 5.9 or 6.2 years, and 50% will have more. So this is the median value. So it does not mean that all of them survive only till 6.2 years. It is 5.7 for pediatric patients and 6.2 for adults.
What is the current survival rate, sir, following the transplant, longest survival of heart transplant and longest survival of lung transplant till date today?
So for
So I don't remember.
heart transplant is 39 years. One patient has completed 39 years. Not obviously not from India, because in India it is available only 10 years. Last 10 years we are doing heart transplant, and lung transplant maybe 8 to 10 years. But I think from Africa, if I am not wrong,
No,
recipient is
from
from
US.
Africa and from US. Okay, from US. So
So
he
39 years
completed
old is
39
from
years.
US. Yeah, and the lung transplantation, post lung transplantation, longest survival of combo is 34 years.
So it is 39 and 34 years.
Yeah,
In fact, it is another quiz question that who is the longest survivor after a heart transplant? But maybe you can ask that in Ahmedabad.
In Ahmedabad, we'll ask that.
Sir, we are not supposed to leak the question, sir, now itself.
So we won't ask.
Thank you, sir. Next slide, please. If platelets or FFP preparations are used in ABO incompatible heart transplant recipients, these products should be matched based on ABO blood type of.
Yeah, so it's a very interesting question, and even I had to think for a while, but it's a donor, and we have to basically match them with the respect to the donor because they carry the antibody, and if you match it with the antigen, and if you match it with the recipient, they'll have the antibody to the donor, and that will cause hemolysis.
Next slide, please. Who performed the world's first total artificial heart?
Yeah, so if any answer in cardiac surgery you don't know, you should always be Denton Cooley, and it is Denton Cooley. So there is nothing much to say. It was done in 1969, way back, almost 56 years ago.
Which was a place, sir, in Texas. Where was it?
Houston. It was
Houston.
in Houston.
Yeah, at that time he was in Houston.
Okay. Next slide, please. Post-transplant monitoring of donor-specific antibodies should be minimally performed at.
Yeah, so I think again the choice is A. The guidelines say very clearly that all patients should be monitored 3 monthly and after that annually. So that is what we need to do.
Next slide, please. According to ISHLT, PAMR format for reporting antibody-mediated rejection, pathology AMR falls under which category?
So pathologic AMR, I mean, I don't know if we are familiar with the term. It is antibody mediated rejection, and it falls under category 2. In 0, like as you can see, it's a negative for pathologic AMR. 1 denotes histopathologic AMR alone. And in 1 plus, you have got immunopathologic AMR alone once again. So when it comes to histopathologic and immunopathologic findings, it is PMR2.
Yeah. Next slide, please. All of the following problems can mimic brain death except.
Yeah, this is again a very interesting question. All of them can cause except malignant hyperthermia. As we know, it's a reversible condition. It happens due to certain anesthetic drugs which are given. The everything else, hypothermia. In fact, I'm sure all of you know that in hypothermia, you don't call that the patient is dead until you have brought them to normothermia. And locked-in syndrome, again, it is different to brainstem death because the patient can still sort of move the eyes. There is voluntary blinking. There is some movement. And Guillain-Barré syndrome, it's a gradual sort of loss of neurological functions. It starts usually in the lower limbs and then moves upwards. So malignant hyperthermia is the answer here.
Next slide, please. Complication with high mortality in the immediate post-lung transplantation period is.
So yeah, so hyperammonemia is the answer here. It's a very uncommon complication. It happens into maybe 1 to 4% of the cases, but when it happens, the mortality is as high as 75%. And as you can see on your screen, it's called HALT, hyperammonemia after lung transplantation. So it's a it's a complication that carries very high mortality.
Yeah, the next one is all of the following drugs increased level of tacrolimus except.
Yeah, so I think the answer here is again D, which is rifampicin, which actually decreases the level. And you have got a list. I mean, you just have to learn this list of things that decrease and things that increase the calcineurin inhibitor levels.
Yes, sir. Next slide, please. All of the following are risk factors for post-LVAD RV failure except.
So PAPI, I don't know if you are aware of the full form of PAPI. I wish we had given you the full form. It stands for Pulmonary Artery Pulsatility Index. And the formula for that is you have the systolic pulmonary artery pressure minus the diastolic pulmonary artery pressure, and you divide it by the CVP. 1.85 is actually the higher the uh, pulsatility index. I should just call it PAPI maybe. Higher the index, better is the prognosis. So more than 1.85 is actually good. So that's the answer.
Next slide, please. Which of the following prophylaxis has to be continued for lifelong lung transplantation?
So it's D. The answer is D. Most of these, obviously, these patients are on immunosuppressants and they are, prone to develop a lot of different infections, but they're mainly antimicrobial. For pneumocystis jirovecii, you have to give lifelong prophylaxis. Usually, the prophylaxis, the commonest drug, I don't know if you've heard, it's Septran, trimethoprim. That is what is used. So that's the answer.
Yeah, I request Dr. Chitan to start, please. All other side effects of tacrolimus except.
So here tacrolimus causes the hyperkalemia, and that is actually very common side effect of tacrolimus. So many patients who are on tacrolimus, their potassium is 5, 5.5, 6, and we have to give them K-bind sachet twice a week or something like that. So rest all are the side effects, and it causes hyperkalemia, and hypokalemia is not the side effect of the tacrolimus.
Next
Next,
slide,
please.
please. Which of the following is the percutaneous mechanical circulatory assist device?
Yeah, so race 3, except Impella is a surgical left ventricle, right ventricle assistation device. Impella is the percutaneous put from the generally from the femoral artery in the cath lab. So that is the percutaneous device. Different kind of different like 2.5 liter support, 5 liter support, RV Impella. So different kind of Impella supports are available, and that is the percutaneous device. Rest all are the surgical device.
Next slide, please.
Next.
Which is the best mode of transplantation for group 1 pulmonary artery hypertension?
Yeah, so group one pulmonary artery hypertension, as we have
Can you show the
discussed,
answer,
different
please?
there are five groups of the pulmonary artery hypertension. Group one is like because of like idiopathic or drug-induced pulmonary hypertension, and whenever there is pulmonary hypertension, it's always better to go for double lung transplantation because when, as I told, when we have double lung transplantation, that PVR will fall. If you do only one lung, single lung transplantation, then still there'll be high PVR, pulmonary vascularizations from the another lung which we have not replaced, not transplanted. So here clear cut answer is double lung transplant, and when we do double lung transplantation, PVR, pulmonary vascularizations will fall, and patient has better outcome.
Next slide, please. All of the following can declare brain dead except.
Yeah, so here first ABC can declare, but anywhere the person or doctor who is associated with the transplant team, like even the transplant physician, surgeon, anesthetist, or coordinator who is involved in the transplant side, recipient side, cannot talk about the brain dead. And actually, hospital makes the committee for that who can declare. So there are in that committee includes us like neurosurgeon, neurophysician, anesthetist, critical care specialist. And surgeon can also do, provided it is authenticated by the committee, local committee, and that local committee have to taken the approval from the state committee for that. So once if we are part of that committee, any doctor can actually certify the brain dead. But except for the who is on the recipient side, physicians cannot declare the brain dead.
Next slide, please. Which of the following is most sensitive method to diagnose aspergillus infection in post-lung transplantation patient?
Yeah, so here
Show the
answer
answer,
is
please.
the bronchoalveolar lavage galactomenon. So we have two, like one is a serum galactomenon and second is bronchoalveolar lavage. But when it's come to the post-lung transplant diagnosis of aspergillus, gold standard is the bronchoalveolar lavage galactomenon. So that is the clear-cut answer for that.
Next slide, please. Presence of de novo donor-specific antibodies in heart transplant recipients is.
Yeah, so de novo means after the transplantation, patient developed antibody against the donor cells. Right. So obviously that donor specific antibodies is every the risk factors for the acute rejection is associated with worse graft survival. So if you find that, that's why we screen patient 1, 3, 6, and 12 months for the presence of donor specific antibodies are not. Even whenever we have doubt, if patient is coming with the like patients on echo, heart is bad, like EF is just 15 to 20%. But if you see biopsy, on biopsy it can be negative, for example, then we also check the donor specific antibodies. If the biopsy is negative but donor specific antibodies are positive, we consider it as a antibody mediated rejection and we treat that patient as the antibody mediated rejection. So DSA, D no DSA is very important role to diagnose the antibody mediated rejection.
Next slide, please. Harlequin syndrome is seen in.
Yeah, so it's the complication of the peripheral VA ECMO, veno arterial ECMO. It's also called the north-south syndrome. So here what happens, we have put is the peripheral. So arterial cannula is from the femoral artery. So what happens, initially everything is fine, but when patient's left ventricle improves, so it started ejecting the blood and head and neck will get the blood from the ejection from the left ventricle, rest of the lower body get the blood from the ECMO. Now, if suppose this patient's lungs are not recovered, only heart has LV has recovered, then whatever LV is ejecting, it is with the low PO2. And so head and neck, whatever upper body supply will be with cyanosis. So they consider they get the blood with the low PO2. while lower body, which is getting the blood from the ECMO is on oxygenator, definitely. So they have higher PO2, better oxygenation. So you can have the differential oxygenation or differential cyanosis. That is called the Helican syndrome. It is a complication of the peripheral VA ECMO. It cannot happen on the central VA ECMO. And treatment is VAV ECMO. So now VA ECMO, you put one more cannula for the venous drainage from the, like, for example, from the right IJV, take that blood, get the oxygenated, and again give it to the uh, right side, and that will be then ejected by the left ventricle, and that upper body will also get the oxygenated blood. Next, please.
As per ISHLT, median survival following heart transplant is.
So already, as Dr. Pradeep has mentioned, for heart transplant, it is 11.9 years. This is latest guideline published in 2024, ISHLT Fast Facts. Before that, it was considered 15 years. Median survival rate was 15 years, but now they are telling it's 11.9 years. But as Dr. Pradeep rightly pointed out, it's just median survival. So more than 50% patient go up to 20, 25, anything more than 12 years also. So we should always see positive side of it. Next,
Next
please.
slide, please. Which of the following is preferred method for the diagnosis of acute cellular rejection post lung transplantation?
Yeah, so gold standard is bronchoscopy and transbronchial biopsy.
Can you display the
So,
answers, please? Yeah, please go ahead,
yeah.
sir.
So anytime we feel after the lung transplant that patient suddenly there are edematous changes on the lungs, and if PO2 or by FiO2 ratio is becoming less than 300, then we should do the bronchoscopy and do the transbronchial biopsy, and that is the gold standard for diagnosis the cellular rejection post lung transplant.
Next slide, please. Which of the following donor recipient predicted heart mass ratio is reasonable to proceed with transplant?
So this is very important question because before this guideline, everybody used to see the what is exact weight of the donor and recipient. So anything plus or minus 30% in the range will be acceptable donor weight under range of plus or minus 30%. But then ISHLT has come with the predicted heart mass. So suppose patient is obese, then obviously, but actually we see the what is the predicted heart mass, and if that ratio of the donor to recipient is 0.86 or more, then it's considered ideal donor for that recipient. If recipient ratio is less than 0.86 or less than 0.7, 0.7, then obviously that patient, that donor is not good for that particular recipient. So predicted heart mass is the uh, actually index to select the which donor is suitable for the given recipient.
That is calculated on what, sir? The ratio has been made up of what?
Yeah, so there is a calculator available on the online, which see many things like a height of the patient, height of the donor, weight of the donor, height of the recipient, weight of the recipient. So, and it is a calculator, and it is online available. So we have to just put the data in that. We have to feed the donor and
Gives the
recipient
data and
data, and it
multiple
will
factors.
match.
Okay.
And it will give us the idea exact. It will count the calculate the ratio donor recipient predicted heart mass ratio, and it is also color coded. If it is lesser, it will give red color score. If it is good, it will give the green color score. How many percentage it's up or down, that also it will give. So it is very good calculator. It's
I
easily
think for
available
the
on
Dr.
online.
Dhiren has put up an app is available on the Android phones, I think, to calculate
Yes, yes.
the.
App is
Yes.
also available for that. Yes.
Thanks. The next question is, as far as the function is concerned, a donor heart should not be used in all the following conditions except Pradeep Narayan, please.
Yep.
Yeah, so it is a very, very interesting question, and its answer is 4, the D, because the catch is the here was 12 millimeters. If you look, that is where the question, the cutoff is. The cutoff is actually 14. So if you look at the guidelines at the bottom of this slide, you'll find that as long as it's less than 14, it can be used. So that was the answer in this case.
Next slide, please. Pulmonary vasculator of choice in primary graft dysfunction post lung transplantation is.
That's again a very simple answer. It's nitric oxide. I think anybody who has been involved with lung transplant knows that. And I think Dr. Chintan already quite nicely talked about the ischemia reperfusion injury, so I will not go into it. But nitric oxide is the answer.
Yes. Next slide, please. Identify this.
So again, that's a very, very interesting device. It's the Abiomed AbioCore, and I just want to tell you a little bit about it. you may or may not be aware that it has been actually licensed for use, but only a humanitarian sort of device exception. So when there are no other options, it can be used. It has been approved by FDA almost 15, 16 years ago. It was approved in 2008. There are about roughly 20 people who have actually received it. The survival is not fantastic. This is used in people who have got no other hope. The survival is about 5 to 17 months in this total artificial heart.
Next slide, please. The drug with the least effect on pulmonary vascular resistance is?
Yeah, so the answer here is obviously vasopressin. And the reason being vasopressin works through V1A receptors, which are not found on the pulmonary veins. All the others, as we know, AD and NORAD, they work through alpha receptors, which are found in both the places. And milrinone works through the phosphodiesterase 3 receptors. So vasopressin does not affect it so much because it's not present in the pulmonary veins.
Next slide, please. Parameter for calculating tidal volume to ventilate transplanted lung is?
Again, so this is a very interesting question. Obviously, we have to tailor it to the donor. And the reason being, if you tailor it to the recipient, if the lung is bigger than the donor lung is bigger than the recipient, then you are underventilating it. And if it is smaller than the recipient, then you are overstretching it and you can damage it. So it has to be tailored to the weight of the donor, not the recipient.
Next slide, please. What is recommended time duration for permanent pacing for inappropriate chronotropic response after heart transplant?
So the guidelines say it's 3 weeks after heart transplant. And that is, I think, all we have to sort of remember. I don't know the science behind it, why 3 weeks, but this is what the guidelines say.
Next slide, please. Prospective or virtual cross-match should be done with PRA.
Yeah, so I was expecting it to be one of the toughest questions, but I think it is one of the easiest one. I think we all know it's 10%. It's a class 1 level of evidence C. It's 10% is the answer.
Next slide, please. What is SOTA Act and when it was passed?
So it was 1994 that it was passed in India, and it encompasses not just heart and lung, but any tissue. So as you can see, it's Human Organs and Tissue Act. So any transplant, uh, even corneal transplant comes into it. Uh, and this act was passed in 1994. There has been a recent revision that is that came out in the newspapers that is being done, but we have not seen the final copy at what changes have happened. So as far as all practical purposes are concerned, this is the last guideline that we have on the subject.
And the entire country follows these guidelines as even today.
Yes.
1994 Transplant Act. Yes, sir. Yeah. Next slide, please. As a general rule, the acceptable ischemic time for a heart transplant is?
Yeah, I think all of us would have got it right. I think it's 4 hours. So,
yes. Next slide, please. A pulmonary vascular resistance index (PVRI) is calculated as?
So it's a D. It's and there is a lot of explanation here, which actually is very, very interesting, because what you are looking at is the gradient. The gradient between basically the pulmonary artery and the left atrium. And the pulmonary artery pressure is one pressure, and the left atrial pressure is measured, as we all know, by the pulmonary capillary wedge pressure. So this is what the gradient is, and that is divided by the cardiac index to get the ratio.
Thank you, sir. I think we completed all the answers and the questions in detail, sir. I would now invite Dr. Abid Gilani, sir, on behalf of INSSLT to address us.
Hello.
Yes,
Hello.
sir. We are not able to see you, sir.
Okay. Okay.
Yeah.
It was very interesting. It was very interesting presentation, and it is a. I am very happy to see the enthusiasm into the participants, and that is and all the credit for this enthusiasm goes to Dr. Dhiren and Dr. Hiramat